Welcome back. So you have done an x-ray, confirmed it's a GDV. You bring your patient back to the exam table, placed two large bore IVs in both cephalic veins, and you're now running 2 bags of fluid. What do we do next? We want to relieve the gas accumulation inside the stomach to decompress it. Let's find out more. Gastric decompression must be attempted after fluid resuscitation is started if it has not yet been done. These two processes can occur concurrently, and by the time you have placed the IV catheters, the patient's hair is being clipped and the left lateral abdominal area is being aseptically prepared. In gastric decompression, you are working against time. When I say every minute counts, it really counts. Delayed decompression causes worsening of the gastric wall integrity and elevated levels of inflammatory mediators. The stomach can be decompressed in 2 ways: orogastric intubation and gastrocentesis. Orogastric intubation is the placement of a stomach tube through the oral cavity and esophagus, reaching the stomach to evacuate the trapped air and ingesta. This is also done for patients who ate something toxic or poisonous, and you would want to do a gastric lavage to evacuate the toxic substance in its stomach and flush it with water. The stomach tube is pre-measured from the mouth to the point of the last rib, which is where the stomach is supposed to be. The pointed area by the blue arrowhead here, just in front of the mouth, must be marked with a tape or a marker to signify that you should not insert the tube further than that point. Remember, the stomach wall is severely distended and it is very fragile. Pushing the stomach tube too deep can lead to gastric rupture and leaking of gastric contents into the peritoneal cavity. Now, most patients are very weak, depressed, and are only semi-conscious when it's presented with GDV. So it is up to you to assess if you can intubate the dog or not. Even if orogastric intubation can be easily done in conscious animals, it is preferred to be done in sedated patients to eliminate the activation of the gag reflex and sudden movements which could interfere with the procedure. If the patient is sedated, it is placed on its lateral recumbency. If it is conscious, the animal is then placed in a sternal recumbency. A roll of adhesive bandage can be used as a mouth gag, as seen in this image, while the bandage itself is wrapped around the muzzle to prevent the dog from opening its mouth and dislodging the roll. This step is not needed for sedated patients. For those sedated patients, you make sure you closely monitor their vital signs. The tip of the gastric tube is then lubricated to prevent frictional trauma to the esophagus. The gastric tube is then passed through the roll of the adhesive bandage in the mouth. Gently rotate the tube counterclockwise as you push it through the hired apparatus and to the esophagus. If it cannot go through the hired apparatus, change your tube into a smaller size. Be careful in rotating to prevent iatrogenic esophageal damage. Gently rotate the gastric tube through the esophagus until you feel a dead end. This is the level of the lower esophageal sphincter where the twisting has closed the esophagus shut. Apply gentle pressure on the stomach and gently rotate and counter-rotate the tube until you feel a puff of gas. Be ready with a draining bucket to catch all the ingesta that will be drained by the tube. Tape the tube around the muzzle and keep it in that position. This procedure comes with its risks, such as rupture of the esophagus or the gastric wall. As we have said in the previous video, the stomach wall becomes very, very fragile after ischemic damage. Let's now watch this video of how orogastric intubation is done on a GDV patient.
What we're going to do is, because this is an older dog and we don't really want to do the torsion surgery, well, it's not that we don't want to, but it's hard on the dog And the owners said, no, maybe we shouldn't do that. And I agree. We're going to try to decompress the stomach with a stomach tube. And then we'll see if once the stomach is deflated, maybe it will return to its normal place. So what we're doing is we're going to pass a stomach tube, and you can even do this on a dog that's awake with a piece of tape in their stomach, but we're going to pass it down the throat, and if it can go into the stomach, then we know which it is now. It's in the stomach, and sometimes we can feel or hear the gas come out. So I'm actually pushing on the stomach, and I'm relieving the blow. And as you look down at the tube, you can see air and liquids coming out. See the bubbles? I want to totally drain that stomach. If you totally drain it and get it back into a normal position, it's possibly this little dog won't need surgery. Okay.
Now, question. What if you do not have a gastric tube? What can you do to decompress the patient's stomach?
What we're going to do is, because
This is where gastric trocharization comes in. Gastric trocharization or gastrocentesis is where you insert a needle into the stomach through the skin for decompression. Though it can only evacuate the gas from the stomach, the degree of decompression done might be less effective than if a gastric tube is used. So, how is this done? The animal is sedated and placed on its right lateral recumbency. The hair on the most tympanic area of the left lateral abdominal wall is clipped and aseptically prepared with povidone iodine and alcohol. Ideally, a 3-inch 14 to 18 gauge over-the-needle catheter or an 18-gauge needle is inserted into the area. If a needle is used, you will instantly hear a gush of air going outside of the needle. If an over-the-needle catheter is used, you would need to remove the stylet first, that metal part of the catheter, and then listen for the sound of air escaping the catheter. You may put pressure around the stylet or needle towards the stomach to hasten the decompression process and to ensure that the stylet remains inside the gastric lumen. You may observe gastric fluid going out of the tube or sometimes blood in severe cases. Now, can you think of any risks and complications of such a procedure? Number 1, splenic puncture. Because the spleen is closely positioned with the stomach, you can accidentally puncture the spleen during trocharization. This can eventually lead to internal bleeding and further loss of blood volume from the intravascular space. This is why it's very important to insert the needle on the most tympanic site of the abdomen. So what's this tympanic site? How would you know? Try to tap the abdominal area, and the most tympanic site would hit back on you like it's a balloon. Though even with this kind of precaution, splenic puncture can still happen. Number 2, most patients who come in with a GDV has an unknown medical history, unless they are a regular in your clinic. Patients with a clotting problem or conditions which predispose them to internal bleeding, or those patients with a heart problem and is on anti-clotting medicine like aspirin, they're all at high risk of bleeding from the hole that was made by your trocar. This leads me to the third reason. I do not advise putting a needle into the stomach wall if you're not planning to open up the animal anyway for a gastropexy. If the GDV is severe and it has reached that point wherein it has caused necrosis on the gastric wall already, this wall can be very fragile and thin, and a small needle puncture can be the break in that wall that it's just waiting to happen for it to become a full-on tear. We do not want that. So after a decompression is done, now we want to proceed with the untwisting part. We will discuss the surgical procedure for this in our next lecture video.